Morning, I'm Dave Cook from the Christian Science Monitor. Thanks for coming. Our guest this morning is World Bank President Dr. Jim Yong Kim. This is his first visit with the group. We were honored to host a number of his predecessors, starting with Robert McNamara back in 1971. We appreciate Dr. Kim taking time out of his busy schedule to be with us today. He was born in South Korea and moved to Iowa when when he was 5. He earned a bachelor's degree from Brown University and a medical degree and a PhD in anthropology from Harvard. Before finishing his Harvard degrees, our guest co-founded the nonprofit Partners in Health, which provides health care in poor communities on 4 continents and was a leader in tackling tuberculosis and HIV/AIDS in developing countries. In 2003, Dr. Kim joined the staff of the World Health Organization, becoming director of its HIV/AIDS department. The same year, he won a MacArthur Genius Fellowship. Along the way, our guest held a variety of professorships and chaired departments at a number of distinguished medical institutions, including Harvard Medical School and its School of Public Health. From 2009 to 2012, he was the 17th president of Dartmouth College, a position he left when he was elected World Bank president in July of 2012. Thus ended the biographical portion of the program. Now on to the ritual recitation of ground rules. As always, we are on the record here. Please, no live blogging or tweeting. In short, no filing of any kind while the breakfast is underway to give us time to actually listen to what our guest says. There's no embargo when the session ends. To help you resist the relentless selfie urge, we will email several pictures of this session to all reporters here as soon as the breakfast ends. As regular attendees know, if you'd like to ask a question, please do the traditional thing and send me a subtle, non-threatening signal, and I'll happily call on one and all in the time we have available. We'll start off by offering our guests the opportunity to make some opening comments, then we'll move to questions from around the table. With that, thanks again, sir, for doing this. Appreciate it.
Dave, thanks so much for having me. It's a great honor to be here. I know this breakfast has a long tradition, and we do know that starting with President McNamara, the presidents have been here. I'm open to talking about anything that you might want to talk about, but probably something that's on the top of people's minds is the Ebola epidemic that's going on right now. First of all, let me just start by saying that I've been watching very carefully about what's going on in New York City, and a couple of things are very striking to me. First, this was a city and a system that was extremely well prepared. I think we learned a lot from Dallas, and looking at the response from both the governor, the mayor, the public health officials, Tom Frieden of the Centers for Disease Control, it was very impressive. They did everything in just the way that you'd want a government or a system to respond. The other thing that I'd like to stress, and we can talk more about it, is we all have to understand that Dr. Spencer is a hero, that he is doing exactly what's needed to actually bring the epidemic to an end. He is a hero in that he went and did the one thing that we need to do in order to stop more cases from coming not only here but everywhere else. We need to have health workers. We need to have experienced health workers. My understanding is that he's a fellow in international emergency medicine, which is extremely good training for something like this kind of activity. And the one thing that now we know in these 3 countries is that we need health workers. There's tremendous work being done, especially by the US and the UK, on building facilities, but it's still not clear where the health workers are going to come from to provide the treatment, the isolation, the infection control that we need right now. The epidemic is still growing. It's really hard to get exact numbers on where we are in the 3 countries, but we know it's still growing. And I think any numbers that you might hear, most of them are about are oriented around thinking how to plan. How big could it get? So it doesn't make any sense for me right now to tell you that it's going to get this big or that, but we really don't know. But I can tell you this for sure, that if we do not improve our ground game quickly, lots is being done. If I look back just a month and a half, there's so much going on the ground now that there was not before. But the biggest concern, and this is why Dr. Spencer's story is so poignant for me, the biggest concern is that we'll build facilities and then we won't have the workforce to actually put them into use. So with that, let me stop and hand it back to Dave, and then we'll talk about anything else that you'd like to talk about.
I'm going to do one or two, and then we're going to go to Mark Seibel, Guy Taylor, Anna from Reuters, Don Lee from the LA Times, and Brett Norman from Politico to start. Let me take you back to something that you said at a Reuters event last week. You said in terms of the global response to Ebola, we're not close yet, we're not close in terms of getting it right. Has that assessment changed?
We're closer now than even we were last week. So things are moving quickly. Facilities are getting built. We're looking at every single option. You know, I just spoke with Margaret Chan this morning. She calls me whenever she needs to tell me anything, and she called me to tell me a couple of things. First, they had a very successful meeting on vaccines, because there are several vaccine candidates. Now, let me just stress, that there is no proven vaccine, so we can't be lulled into thinking that a vaccine is going to solve this problem. Even if we did have a vaccine, we'd need health workers to administer them. And so, but the one thing that wasn't clear is how a vaccine trial, for example, would be worked out. Just yesterday, they had a meeting with the US, UK officials from the private sector, and they've worked that out. So things are moving day to day. She just told me that one of the big issues, how do you pay health workers? So they're now working on electronic payments for health workers. And you know, all this tells you that the speed and the momentum of the response is growing. But what she told me this morning, and what still remains true, is that we don't have enough health workers, and we're not quite sure where they're going to come from.
My guess is you're going to get asked about the U.S. Aspect by other people, so let me ask you something that may not come immediately to mind, and that's what you see as the role of fear and the media's behavior in dealing with all of this. You said in an op-ed in the Washington Post, written with your Partners in Health co-founder Paul Farmer, the crisis we are watching unfold derives less from the virus itself and more from deadly and misinformed biases that have led to a disastrously inadequate response to the outbreak. So what's your sense of how the media's behaved? What's your sense of the role of fear in dealing with this?
Well, I have, you know, the media has varied tremendously. I have seen extremely high quality reports that go into detail about how the virus is transmitted. And then I've also seen very sensationalist media reports. You know, we take this fear very seriously, because from the perspective of economics, what we've learned is that 80 to 90% of the economic impact of these outbreaks has to do with fear and what we call aversion behavior, fear, than it does with the virus. So the virus can have a relatively limited impact, and then the fear has this huge economic impact. That's what happened during the SARS epidemic, for example. So one of the things that's really, really critical is to explain and be really accurate and specific about how these things evolve, and that's what they did in New York last night. And in watching at least part of the press conference, I thought that the very clear explanations, both on the part of the public health people, but then having political leaders there, clearly knowing what the facts are, and then reassuring the population was very important. Now we'll see what happens today in New York, but I thought that that their handling of the information piece of it was extremely good.
And finally, for me, there's a study from the World Bank on the economic impact,
right.
And several different cases. One case at the low end, 3.8 billion. The high case, 32.6 billion. But that, I guess, assumes that it's contained in southwestern Africa. What is your sense at the moment? Has your sense of the economic impact of this globally changed at all in the last week or two?
Well, it all depends on whether we can get the response in place. You know, if you take the perspective of the virus, you know, the most important thing right now is to stop it where it's spreading quickly, right? And there are still parts of the three countries where it's spreading quickly. And so there's really only one way to stop this from continuing to export cases all over the country, I mean all over the continent and all over the world, and that is to redouble and redouble and redouble again our efforts on the ground. So the agencies that are supposed to be working on this, the World Health Organization, the UN, funding organizations like ourselves, the United States government, the UK, France, and then all the other governments, they've really stepped up their response. But unfortunately, we were late, so instead of having a few dozen cases. I mean, the largest outbreak up to date has been 425 cases in the past. There are more health professionals who have been infected than the number of cases of the largest epidemic previously. So we're behind because it's moving so quickly. But while there is optimism about what's happened, there's still a long way to go. And if we don't solve the health worker problem, all of the efforts to date will simply not have the impact that we need to have.
Mark?
You know, you come to this with an interesting expertise, and you're sitting in an interesting position now. What do you see as the World Bank's role in this, and do you find the organization suited for the vision you have of how it might benefit the situation?
So the World Bank is very involved in financing health, and there's a good reason for that. You know, Larry Summers just did a study. It was now 11 months ago, but in January of 2014, Larry Summers published a study that showed that in low to middle income countries, fully 24% of the economic growth in low and middle income countries from 2000 to 2011 was due to improved health outcomes. So the fact that life expectancy went up, that maternal mortality went down, that infant mortality went down, those interventions that led to longer life and better health outcomes accounted for a quarter of economic growth. So we're involved in health because it's so important for growth. In this particular case, we have a crisis response window, and it's one of the only sources of readily available cash that we can move to developing countries. And because the other traditional funders weren't stepping up, and because there wasn't a fund that immediately disperses when you have outbreaks like this, we had to become that organization. But here's what we're focusing on now. You know, we've developed these very interesting instruments. They're almost like insurance instruments, and we call them catastrophic drawdown bonds. And what we do is we go into a country like Mexico and we say, the last time you had an earthquake, it was difficult getting the cash to be able to respond. And so we've worked out a way that the next time something like that happens, there is a big chunk of money, hundreds of millions of dollars, that as soon as they have a disaster, those funds will disperse. And so inside our organizations, people started saying, why don't we have something like that for outbreaks like this? And so that's what we're working on right now. And I think that, for the medium and the long term, is exactly our role. We can use our balance sheet, we can set up systems of contingent liabilities so that a large fund, billions and billions of dollars, can be set up, but will only disperse if there's an emergency like this. Because that was the problem. As much as organizations like MSF and others and the other charitable groups that really brought this to everybody's attention, as much as they would have liked to scale up, there wasn't the resources, there wasn't the sort of health worker core that was ready to go. We now know we have to build that. So we will work on the financial pieces of it. And our hope is that together with the global community, we can set something up that will work like this. So let's say something even worse than Ebola, a deadly pandemic flu, for example, breaks out somewhere. If we can get billions of dollars moving right away, then we can bring that the emergency health worker corps into fighting those epidemics where they exist. And if you have a fund like this, our hope is that it would even work as an advanced market signal for vaccines and drugs. Right now, vaccine makers would like to go forward, but it's hard for them to find financing because they're saying, even if there was an outbreak, would there be any interest in your product, or who would pay for it? And this, we hope, could take a step toward answering that question. So immediate response, yes. The link between health and economic development, no question. But even protecting from downside risks to the global economy, this is one of the things I think we really have to do.
Sure.
Go ahead. Just to follow up quickly, how much money did the World Bank pony up right at the beginning when the fund shortfall?
So really, before anyone else stepped up, we pledged $200 million. And then afterward, when we saw that it was a much more serious epidemic, we did 200 million more. So the total pledge is 400 million. And usually this takes months to disperse. I mean, 3 months is an incredibly rapid disbursement. But once we saw the problem, from the time we took it to our board to the time it was in the 3 countries was nine days. Now, normally we just don't work like that, but this was so crucial that we did it. And this is going to, the first 117 million is on the ground, and it's paying for everything from supplies, protective gear, to health worker salaries. We bought ambulances because ambulances were needed to carry the patients. So we're really doing anything that's needed right now. But a big chunk of that money also has to be for building back those health systems and also trying to get the economies going. So our private sector arm, IFC, has now committed to increasing its activities. The economic impact in these 3 countries has already been devastating, and we now have to really think about rebuilding those economies. All 3 of them have come out of conflicts over the last decades, and the last thing we need is for this epidemic then to lead into another situation where they move back into conflict. So we're trying to do many things at once, but right now the focus has to be on putting the fire out.
Guy?
Thanks so much for being here, Mr. President. My name's Guy Taylor from the Washington Times, and I'm probably going to be that guy because I want to try to shift the conversation just for a few minutes, and I'm sure we'll go back to Ebola, and try to bring it inside the World Bank for a minute. There have been a lot of articles, some I've written and a number of others here, about unrest among the staff inside the bank. Memos circulating among rank and file economists. There's one out now that's calling for people to hold a rally in the lobby of the bank every Thursday. There have been several such large rallies. Some of these people mostly won't give their names, but are accusing you on paper of gross mismanagement, of a restructuring of the bank. I wanted to give you an opportunity to respond to that publicly, but I specifically wanted to ask, one of the things that's come out is this sense of a kind of culture of fear inside the bank. People complain about this to reporters, and I wonder what you're doing to address that, because budget cuts or reforming and restructuring are one thing, but when a culture of fear takes hold, as everybody in the media I think understands, it's a difficult thing.
Well, when I took the job in July of 2012, the questions that I was getting in a pretty pointed way was what is the relevance of the World Bank today? And the issues that kept coming up were, are you relevant for middle-income countries anymore? And one of the things that that was worrisome is that we were reaching what we call our single borrower limit for many of the most important borrowing countries. In other words, we were running out of space to support middle-income countries. The other issue that came up was the sense that as a knowledge institution, we had fallen backwards, that we weren't providing state-of-the-art knowledge to all the different countries who are our clients. And then what we did was we did a survey of the entire staff. And the survey was extremely critical of the bank as it was. And so the issues we tried to tackle were, how can we continue to be relevant for middle-income countries? And the second issue was, how can we ensure that we're moving the best global knowledge to every country? And one of the things we found, one of the pieces of data we found, were that when we asked technical specialists, how much of your time do you spend providing your technical expertise to other regions? Because they're all locked into regions. And it came back around 1% of their time. So we knew we needed to do a couple of things. And then we looked back historically, we talked to everybody in the House, and we decided that we needed to make some pretty fundamental root and branch changes. And when we decided that we were going to do that, I told everybody to begin with, this is going to be really hard, because it hadn't happened for 20 years. There had been really no structural change for 20 years. This talk of moving toward a global knowledge system, talk of trying to increase our lending capacity, all of this was on the table, but nothing had happened literally since 1997. So when we started in, we tackled a very robust agenda. And we did it in a time of historically low interest rates. So historically low interest rates affect us because that means our income is lower. So the only way that we would have been able to do that, to grow our capacity to lend to middle-income countries and to have global knowledge, was at the same time to do a review of our expenditures. Now, it turns out that an expenditure review hadn't been done for a long time, and I suspect that all of your organizations have gone through expenditure reviews. We had not for more than a decade. So what the board told us was, we will work with you and let you increase your lending capacity, and we support the move to go to global knowledge groups, but you really have to do something about efficiency and your expenditures. So the complexity of this is we did it all at once. And the reason we did it all at once is because each was contingent on the other. You can expand your lending to middle-income countries, but you have to go through the expenditure review. And if you can expand your lending to middle-income countries, the only reason that they would want more lending is if your knowledge was significantly better. So we're in the middle of this, and people are absolutely understandably worried about their jobs. They're worried about what the system will look like. And in big multilateral bureaucracies like ours, when people get used to a way of doing things, no matter how much they may be critical of it in a survey and tell you that there are steps that don't need, et cetera, when you change it, it's very unsettling. So we knew that there would be many course corrections that we would have to go through. And we're in the middle of a course correction right now. And the rallies have happened. And after one of the rallies, I had a town hall meeting, and we spoke about specific issues. And there were some issues that I was aware of, but then there were others that were brought to my attention in a very clear way at the town hall. The next week we had another town hall, and we made some policy changes. So I would just put it this way: I have great empathy and sympathy for the people who have to go through this and are still uncertain about their jobs. But the only thing we can do is to keep going, make sure that the changes happen, and then everybody will know soon enough whether or not they have a job, or how the process of making decisions around jobs will go forward. I've learned a lot from this process, and one of the things that's most important is that when you have 188 governors, when you have a live-in board, our board lives in and works with us inside the institution, 25 executive directors, people from 100 different countries who, English is a language in Washington, but there's many different languages. With this much cultural complexity, with an organization that's so complex that hasn't gone through a change in a long time, it's tough. So there's no doubt that it's tough. But there are things that are happening already that I think are because we made these changes. For example, the response to Ebola has not been a regional response at all. It's been a response that's involved all kinds of different expertise in the bank, and now we're structured so that we can do that. We recently were able to put together a price on carbon, a statement on a price on carbon for the UN General Assembly. And again, that was a an institution-wide effort that really wouldn't have happened before. So I am extremely optimistic and confident that this is going to get better. Yeah.
Real quickly, because we've got a bunch of other people waiting.
Real quick, I appreciate your answer. You did hold these meetings, town hall meetings. At one of them, the issue of your CFO's bonuses came up. And I'm curious to know, this is Bertrand Badre, and he'd been given a signing bonus, and then on top of his scarce skills bonus, and you announced to the staff that he would renounce his bonuses. Yeah. However, the World Bank press office then came out and said he'd already received 70% of his bonus, and he was going to be keeping that, but foregoing the last part. Could you clarify that? Because this is going to be broadcast, and I'm sure there are people inside the bank that know that you're the one who has the answer to that question. Is he actually giving his bonuses back, or he's keeping them and not getting them going forward?
No, he's not giving what he's already received back. I mean, that would be a very difficult process to go through. But he's foregoing it in the future. And let me tell you why we have a scarce skill premium. The scarce skills premium is because we are a rules-based organization, And salaries for staff in different countries are based on local salaries. And it's very difficult for us to attract the kind of talent we need in many places in the world if we don't have a scarce skills premium. In the case of Bertrand in particular, he was the CFO of one of the most important and largest banks in France, Société Générale. And so we were trying to help meet the salary cut that he was taking, the pay cut that he was taking. Now, I think Bertrand did a great thing in refusing to take any more, but we're not asking him to give what he already had back.
Anna from Reuters.
Thanks for coming and talking about this again. I'm going to go back to Ebola for a second.
A little louder, please.
Yes, can you hear me? I wanted to ask you about the chance of how the disease is spreading or not in West Africa. If you talk to experts looking at the number of cases and the fact that even in Nigeria, as we talked about, the response was huge for just a small number of cases, and given that we don't have enough health workers, the expectation is this is going to spread to the neighboring countries, and it's already massing on the border with Cote d'Ivoire. So what does that mean for the strategy for how to deal with this? And also, what does it mean for the U.S. response? Because the U.S. has come in, and so far they've said their troops will not be even coming near the disease. But do you think that's a realistic strategy, and what is the exit point for that?
So what happened in Nigeria was really a model. But it was a model that was workable because there was one cross-border case that led to about 20 cases. Right? So just to give everyone the numbers, it was over 200 physicians, over 600 other health workers, upwards of more than, we understand it's more than $10 million of cost. And they did almost 19,000 home visits where they took people's temperatures. This was doing the contact tracing. So it was a textbook public health response. But if you can imagine if there were 100 cases or 1,000 cases that came over the border, it would challenge even Nigeria to be able to respond effectively. So right now the strategy is to focus on what are the critical things to do to make sure that you can somehow knock down the speed of the growth. So the two things that people have identified as the most important things are safe burials, and then identifying the people who are sick with Ebola, and then at the same time trying to provide them both treatment and preventing further infection. So I think the goal now is 70% safe burials and 70% detection of the cases. Now that's actually not the classic public health response, because what they're basically saying is that it's going to be difficult to find every case right now, and it's going to be really difficult to do all the contact tracing. So I think they're being extremely practical and trying to take that first major step, knock down the growth as much as you can by going at the places where, going after those problems that are spreading the virus the most. And then after that, you may be able to then bring in the classic public health response. But right now, that's the reality. We're now using, not the ideal techniques, but it's because the epidemic in those three countries is too big. Now, if we had thousands of health workers going in, what we could do is get all of that done and then get to the classic public health response of doing all the contact tracing. That's what you'd like to do. But in a situation where you don't have enough health workers, you have to focus on what are the highest impact things that you can do right now.
Do you think it's going to spread to neighboring countries, and what does that mean for the strategy of how to fight it?
So we're also the World Health Organization, the whole global response is working with each of the neighboring countries to put their response in place. So I think there's no doubt that the neighboring countries are much better prepared than Liberia, Sierra Leone, and Guinea were. But it's going to be a challenge. It's going to be a challenge to respond. And if it's one case at a time, their systems may be able to respond. But if we don't get it under control and hundreds or thousands of people start coming across the border, then I think we're going to have a very, very serious problem.
We're going to go next to Mr. Lee from the LA Times, Brett Norman from Politico, Michael Lindenberger from the Dallas Morning News. Ian Talley from the Journal, and Mark Trumbull from the Monitor. Mr. Lee.
What, with the G20 coming up and the leaders getting together, what are you expecting specifically? Maybe what are you looking for in terms of the response to Ebola? And secondly, on a non-Ebola question, there have been reports about the U.S. Actively opposing China's efforts to build a development bank, and that could rival World Bank. And I wonder what you think of that effort.
Yeah. So I suspect there will be talk about Ebola at the G20. And I think, you know, both President Obama and then yesterday Prime Minister Cameron have been very loud about really asking other countries to also make donations and to do their part. I'll certainly give the same message, that we still need resources and we still need health workers. So I'll certainly give that message at the G20. But I think at the G20, the topic of discussion will also be global growth. I mean, this is what the two items that the Australians have really focused on for their hosting of the G20 has been a target for global growth, and that's the 2% global growth target. And the interesting thing is when the OECD and IMF did a survey of all the different economic strategies that are currently being carried out, that if everyone did what they said they were going to do, there's a possibility to get to 1.8% global growth. So in that sense, it's a relatively positive picture. But then the question is, will everybody implement all the structural reforms, for example, that they need to reach that target? That's going to be one of the discussion items.
You mean at 1.8%?
Yeah. And so, the other issue of infrastructure gets right to your second question. And one of the things that the Australians have identified is that there is a massive market failure right now. There are lots of great infrastructure projects that could both boost the growth of economies, especially in developing countries, and there's lots of capital sitting on the sidelines earning very low returns. And the win-win situation could be that we find some way of mobilizing that capital that's sitting on the sidelines and get it invested in these vital infrastructure projects. And so the Australians have really focused on building something called the Infrastructure Center, Global Infrastructure Center, that will be a clearinghouse of information and opportunities to bring the capital on the sidelines and the infrastructure projects together. Now, that's exactly what the Asian Infrastructure Investment Bank is going to do, and it was just launched yesterday in China. You know, you'd have to ask the United States government what their take on this is. I'll tell you our view of it. The Chinese government began talking with us very early on, you know, really sort of immediately after they had this idea. And the idea was that, especially in Asia, there's nowhere near enough money for infrastructure investment. So the estimate is there's $1 trillion to $1.5 trillion in additional investments that we need in infrastructure in developing countries alone. So if you put all the multilateral development banks together, we're about $45 billion. If you look at the private sector, from 2012 to 2013, private sector investment in infrastructure in developing countries went down. Okay? And so, and the figure in 2013 was around $160 billion. So all the infrastructure investment together doesn't even begin to meet the need in developing countries for infrastructure investment. So our perspective is that any institution that comes to the table to try to make these investments in infrastructure, we welcome. And so we've actually been working very closely with them. And they want to utilize our technical expertise. We've been doing everything from project preparation to implementation support, to bringing multiple different groups together to finance projects for a long time. So the Asian Infrastructure Investment Bank it should be a very welcome addition to the current situation, which is a woeful lack of financing for infrastructure. Now, the politics of it, we are not a political organization. It's actually in our Articles of Agreement that we don't get involved in domestic politics. So you'll have to ask the U.S. the position on it. my sense is that we could work with them very well.
Are you personally hearing concerns from Chinese officials directed to you about the U.S. efforts to oppose it? And
I have not heard. No, I've not heard from Chinese officials.
Do you feel threatened?
Not at all.
For the bank?
You know, we without question know that there are many, many more infrastructure projects that are worthy of investment than we can invest in. We know that for sure. And so I think the critical thing for us would be to make sure that our efforts are well coordinated. I can even see co-investing in a lot of different projects. I mean, one of the outcomes of the Australian G20 was that we established something called the Global Infrastructure Facility for just this purpose. Because we know that, you know, I think we did almost 30 billion last year, 20-some billion last year in infrastructure spending. And again, that's just not nearly enough. So what we did was we've just launched a facility that we will put some of our own money in, but we'll do all the project preparation. We'll use our safeguards, and then we're going to try to attract money from other sources. For example, sovereign wealth funds that wouldn't think naturally, sovereign wealth funds from Europe or the United States that wouldn't naturally think to invest in infrastructure in developing countries. But if we're involved and we can make it clear that the risk reward ratio really makes sense, then we can bring some of that capital into building, you know, roads and highways and sources of energy in Africa.
Mr. Noor?
So, apart from Mr. Duncan, the first case of Ebola diagnosed here, the record of treating patients has been extremely good so far in the U.S. And with the two nurses who were infected, they seem almost to have cleared the virus before an average person even shows symptoms or close to it. Are there specific early interventions that we're learning about here that might be able to be applied in Africa if it gets to that stage of catching it early enough, or is it just general hospital care?
Well, so the Ebola virus is a very interesting virus in the sense that it's really not well adapted to exist in the world, in the sense that in a developed country, if you prevent any further infections and you give intensive care to the people who are sick, you can stop its spread very, very quickly. It is the reason it's spread in those three countries. It's because it's opportunistically taken advantage of the fact that those health systems were not developed to be able to either detect, treat, or prevent further infections. So it only can spread if you're falling down on the job in terms of providing healthcare services. And so I think we've all recognized that that the next thing we have to really do is to just commit to putting in place adequate health services in every country in the world, because it's going to be the country that doesn't have those services that's going to be the accelerator of future epidemics. We now understand that, and we've got to get better at it. But the treatment of it is really supportive care, right? So there are some candidate drugs, there are some candidate vaccines, but it's supportive care, meaning that what happens is when the virus gets into cells and the cells start leaking, you lose fluids on the one hand, and your electrolytes, potassium especially, but your electrolytes get out of balance. So what you need to be able to do is to replenish those fluids. Now there's this great story of Dr. Korkor from Liberia who survived, and the story was that he forced himself to drink 12 liters of fluid a day, and he forced himself to eat by holding his nose, right? Now, in any modern hospital, you wouldn't have to do that. You would provide intravenous fluids, and if needed, you'd provide either nasogastric feeding or even intravenous feeding. Right? So, in other words, all the tools we have, all the tools that we need to get survival rates up very high, we actually have. And so, one of the efforts that we're trying to make in these three countries, and this is especially the focus of my former colleagues at Partners in Health, is to try to increase the capacity to do things like monitoring and managing electrolytes and providing intravenous hydration. Because for Dr. Korkor survived, but I think just about all of his colleagues, the nurses and others that he worked with, died. Because it's really hard to drink 12 liters of fluid a day and hold your nose to eat. But any modern medical center would have given those nurses a much, much better chance at survival. So what we're trying to do is to argue that we have to put in place in these 3 countries an extremely high level of care, intravenous fluids, electrolyte management, so that the incentive is for people in those 3 countries to stay where they are. They want to stay where they are. They want to stay in their home country. They want to go back to work in their fields. They want to go back to their jobs. But if you're in a situation where those things are not available and you know that survival is much higher elsewhere, the incentive is to leave. So this is something that I just can't stress enough. We've got to get beyond sort of nihilistic notions that nothing can be done. The only way to put it out is to put in as high a quality of services as we possibly can. Do the things quickly that we know that will slow things down, like burials and identifying who they are. But if you tell patients, we're going to isolate you. We're not going to give you any intravenous fluids. We're not going to give you any tube feeds or anything like that. But we're going to make sure you don't infect anyone else. Well, if you think that going into isolation is basically a death sentence, then unfortunately the incentive is to go somewhere where it's not a death sentence. So that's the challenge. That's why we need health workers so badly.
Michael?
Thank you for being
From Dallas Morning News.
here. 2 questions, one specific to Dallas. What did we learn? What were the mistakes or what were the learnings that you didn't see or that you saw took advantage of in New York?
Well, I think, first of all, we now have a much higher level of suspicion, and we're paying much closer attention to travel history. So, you know, Dr. Spencer is a trained professional, so he was taking his temperature twice a day from the time he came, and you know, the fact that he made the call and got to care literally the morning when his temperature spiked, I think suggests to me that the chance, just as everyone has said, the chance of infecting others before that was as the Department of Health person said, almost nil. Right? So I think in Dallas there was just not the level of heightened awareness and suspicion that this might come to Dallas. And so I think it's on the one hand unfortunate that happened to Dallas, but it's fortunate that we've learned from it. And my understanding is that because of that experience, health systems all over the United States are now at a level of preparedness that they simply had not been before. And so it's the preparedness, it's thinking ahead. Because as I said, there's no miracle drugs, there's no magical, surgical, or other procedure that stops it. It's high levels of suspicion so that when you know someone might have Ebola, you isolate them right away. And then when they get sick, you provide them the kind of care that they need to survive the infection. So, you know, I don't know exactly what the number will be, but I suspect that for cases caught early, and Mr. Duncan unfortunately died, but it was probably because, you know, we were a little late in getting to treatment. If we had treated him earlier, you know, I think the chances of him surviving would have been much higher. And if we can, if that's the story, and that I hope that will become the story, that when cases are caught early, and when they're caught early in a prepared healthcare system like the United States, that not only do we prevent infections, but survival is very high.
And the other question is, you keep mentioning the importance of getting healthcare workers. Given that the cases that have made the most attention here in America have centered on healthcare workers, how are you going to convince thousands of folks, either from here or elsewhere, to go put themselves at risk, you know, apparently?
You know, it's a great question, and that's why I started with saying that Dr. Spencer is a hero. You know, Dr. Spencer understood this epidemic. He understood that the only way to protect Americans in the medium and the long term was to treat, in his case, Guineans. And he understood that. And that is actually the case. So even after Dr. Spencer came back with Ebola, I would still say that what we need now is for physicians, you know, we take various forms of an oath. And the oath is that, you know, that we'll do everything we can to protect ourselves. But our job is to go out and treat those who are sick. And if you have a global epidemic raging in 3 countries, I think it's extremely noble, but also very much in the spirit of the oaths that we take in becoming physicians. And so I wish him the best. I hope he gets better and gets better quickly. And I would not at all be surprised if he goes back and continues to treat people in those countries. And I would urge others to seriously consider going and helping.
Mr. Talley from the Journal.
Wall Street Journal. My colleague in Monrovia has said that there are numerous anecdotal cases of workers who aren't getting paid the cash that, including yourself, or the bank has provided. What sort of accountability structure do you have and assurances do you have that the cash is being spent as intended and isn't being siphoned off into some accounts? Secondly, nobody's mentioned this. I'm just curious whether there's been any mention of secondment, your secondment to oversee global efforts on this. You constantly seem to be saying that there is a shortage of supply, a shortage of action. You seem to be pushing, you seem to be knowledgeable what's going on, and there's been criticism of other efforts. Yeah, and finally, if you could, can you elaborate just what your understanding is on the shortage of healthcare workers? What are we talking about here? How many thousands are we short?
So, Ian, as you know, we have been aggressively trying to lead the fight against corruption in developing countries since 1996, when Jim Wolfenson, it was unknown for people like the president of the World Bank to use what they called the C word back then, corruption. And his aides at the time begged him not to say corruption. And he then went out and gave a speech called The Cancer of Corruption. And ever since that time, people like Paul Volcker and others have been working with us and with all the other institutions to really follow the money as carefully as we can. So every single project is audited. This one will also be audited. We have people on the ground who are following the money. Our understanding is that a lot of this is just related to the inefficiency in the system. On the other hand, if there is corruption, if there are people siphoning off these funds, we have about as robust a system as one can imagine in settings like this to follow it afterwards. So I think it's really, as I said, Margaret Chan, and leading into the next question, as I said, Margaret Chan this morning called me at 6:15, by the way, to tell me that one of the things they're trying to do is to put electronic payment systems in place. And now, we actually know that there are great examples of electronic payment systems that are already working in Africa, and M-Pesa is one of them in Kenya. And so it's one of the things that we're going to work on over the next literally days to weeks to try to get that system on the ground. And if we can do something that's more automated, that people get paid, on a card with a cell phone, we'll put it into place. Now, in terms of leading, I actually have a day job, Ian, and the response is being led, I think, by all the appropriate people. So the Secretary General is very personally involved in the response. And, as I said, Margaret is 24 hours a day, Margaret Chan, the head of the World Health Organization, 24 hours a day, working on this issue. They're the ones who can do things like convene a meeting on vaccines and come up with a protocol to go forward. They're the ones who can convene all the right people to have the kinds of conversations that need to be had about where to go. It's very interesting. They've brought in, the person who's running the response now is probably the person who has the most experience in actually doing things on the ground, and his name is Bruce Aylward. And Bruce is an old friend of mine, but he's been running the polio eradication response, and that's a huge implementation effort. So I think now that he's involved, there's something that you probably haven't heard of, the Global Outbreak Alert and Response Network, GOARN. They have about 300 people that were brought together around previous epidemics, and they were critical in managing the SARS epidemic. Now just about everybody from that network is in those countries working on the response. So I think there's a lot of I think there's a lot of activity in organization. I don't feel like I need I would need to, or and I haven't been asked to step in. But one thing that's really worked, Margaret and I are really old friends. In fact, I hired Margaret Chan as part of the transition team in 2003 when I was leading the transition for the new Director General. So I've known her for more than a decade, and I know these players so well that it's been really helpful for me to be in this position, being able to put resources in very specific places in collaboration with the others. I think that's not the issue right now. The issue is continuing the momentum and at the risk of repeating myself too often, getting the people in place who can actually make it happen.
We've got about 5 minutes left. We're going to go to Mark Trumbull, then the gentlelady from Figaro, and finally Scott Horsley from NPR. Mark?
Thank you. You've been talking about the importance of Russian resources to the West African region, and we have our hands full trying to do that and get health systems here at home in the U.S. Ready in cases like New York. But is there also a need to get going on that wider public health system? I mean, could this crop up in other developing countries that aren't ready, and are resources being mobilized for that? And how so?
Great question. Let me answer the health workers question. I forgot, Ian. It's thousands. I can't give you an exact number, but more than that, it's thousands who rotate. So it's really hard to do this kind of work for a year at a time. So the MSF also has rotations, and we need literally thousands and thousands of trained health workers who will need more training around Ebola to step up and volunteer. And we would love to see hospitals, systems in the United States volunteer numbers. We'd love to see countries all over Europe. Cuba has stepped up really quite impressively. We'd like to see more and more countries do just that. The answer is yes. Could another epidemic come on top of this epidemic? Yes, absolutely. Could another epidemic that spreads much more quickly and is just as deadly crop up? Yes. All those answers are yes. And so I think this is a wake-up call. I hope this is a wake-up call. And this is why I'm so focused on getting this global facility put together, right? Because if we go out and say, you need to put billions of dollars into a fund, I think there's going to be a very negative response. But if we say that we need to set up an instrument that you'd only have to pay back if it disperses, and it would only disperse in the face of a terrible emergency, then I think we have the beginnings of a discussion. So I actually began the discussion at the G20 meetings, and there has been a lot of interest, and so we're going forward. We're gonna put something together, right? Now, but you also need basic public health infrastructures in place in every country in the world, and it's really not that expensive. It's affordable and doable, and this is a conversation that I'm having with Tom Frieden of the Centers for Disease Control all the time. So we're having that conversation as we go, but for now, the focus has still been on the immediate response.
And is that important for Ebola or just for the future?
Ebola, Ebola is not an airborne infectious disease. If it was, it would be an issue for Ebola. But Ebola, because it moves relatively slowly, you have to have direct contact. We're really focusing on the countries in the region. If they get on planes and go to Europe and the United States, again, I think the awareness is so high that the systems are more prepared now than before. But in the medium and long term, we've really got to get on this task.
Ms. Mandible.
Thank you, Dr. Kim, for doing this briefing. I was wondering about...
A little louder, please. Thank you.
I was wondering about how is organized, the response. I mean, you've been insisting for the whole hour about the importance of having these health workers on the ground. What is what the U.S. military are doing now? Is it balancing the lack of health workers? And how are you thinking the response in terms of the rotation? That means when these health workers go back to the U.S., like this doctor from New York, is it imaginable that they would wait in the country where they've been working in order to make sure they don't have Ebola before going back, or is it not imaginable in the way you're going to organize their rotations?
Well, I think, you know, the rules right now, and the new rules coming up, are that if you've been to those countries, depending on your level of risk, the CDC is going to ask you to take your temperature on your own 4 times a day, and then call into a call center to report what your temperature is. And the reason that's so important is, and it's reflected in what happened in New York City, is that the minute your temperature goes up, or the minute you have symptoms, you have to report yourself and then go into quarantine. Right? So if that's possible, if that system is in place, then I think it's still possible for health workers to go and come back. Right? The fact that you're not infectious until you have symptoms is an advantage for us in this epidemic, which means that people should be able to come back and forth as long as we have a system in place that detects symptoms the minute they happen. And that's what the CDC and USAID has put into place now.
Last question, Scott.
Dr. Kim, you talked about trying to fight the nihilistic sense that nothing can be done. I know this is something you've wrestled with in other contexts in your career, and I wonder if you can talk sort of more broadly about the challenge of trying to convince people that first world medicine can make a difference outside the first world, and has experience made us any better at that?
Thanks, Scott. You know, so my own experience in this is that we encountered an epidemic, an outbreak really, of multi-drug resistant tuberculosis. This is tuberculosis that has developed resistance to the 2 most important drugs, and it's much more difficult to treat. And we found a really large number of cases in one community in a squatter settlement in Lima, Peru. And so with tuberculosis, which is airborne, it's infectious airborne, so I actually have treated patients with deadly diseases, and they could actually cough it on you. What we knew is that the only way, and it's the same story, the only way to stop this epidemic, this outbreak of MDR-TB, of multi-drug resistant TB in this community, was to treat the people who are sick. Because once you treat them, they stop becoming infectious. You knock out the infection in their lungs, they stop transmitting it. Now you have to treat them over 18 months. It's complicated, but it's the only way to stop an outbreak. So when we said we got to treat it, everybody in the public health community said to us, it's impossible to treat, it's too complicated, you can't possibly do it. And then we kept saying, so but what do you expect us to do? Well, just sort of turn your head. And we knew that this was going to become an even bigger problem in other areas, especially in Africa. There was an outbreak in the Russian prison system. So we fought for years, 4 or 5 years it must have been, to convince the World Health Organization and other public health bodies to say, okay, we've got to treat this in developing countries. What happened here, I think, was the sense that, well, gee, you know, these countries don't have any of these capacities, and so, gosh, can we do this, can we do that? Instead of saying, oh my God, this is happening, what is the adequate response to this epidemic? Safe burials, identify people right away, provide treatment so that you're not putting them into quarantine to die, right? And I think it took time to get over this sense that you couldn't do it in these 3 countries. There is no sense like that now. There's no sense that we can't do it. There's only how on earth are we going to do it, and what are the things that we can do right now, what are the things we do later. So we are now on emergency footing. We are now on a war footing. But it took us a long time to get there. And I think my own sense is that a part of it was a sense of sort of hopelessness that you can't do anything in these 3 countries. So I hope that's over. I fear it's not, Scott. That's why we want to put these financial mechanisms in place. See, when the finance ministers begin to understand that, oh my goodness, the downside risks to the global economy, to my economy, are huge, then I think we can make some progress. And it's always been the wish of global health people that they could have conversations with ministers of finance. So now that's my job. Part of my job is to have conversations with ministers of finance. And I think we can put together mechanisms that don't require huge amounts of upfront investment, but that could protect us from outbreaks in the future.
This has been fascinating. Thank you for doing it, sir. We really appreciate it.
Thank you.